Good morning, good afternoon, and for some of you, good evening. Thanks so much for joining this webinar. It's great to see you all today. My name is Soumya Alva, and I'm the Senior Male Director for the USAID-funded Momentum Knowledge Accelerator and the Senior Research Monitoring Evaluation Advisor with JSI. Today's webinar is hosted by the Momentum Monitoring and Evaluation Innovation and Learning Working Group. As many of you know, Momentum is USAID's flagship multi-award program. It's a suite of awards that builds the capacity of national and local partners in low and middle-income countries to accelerate the reduction of preventable child and maternal deaths globally. Using a more targeted, context-specific approach, Momentum works to increase the ability of partner country institutions and local organizations to create demand for and deliver and scale up and sustain quality evidence-based interventions. So the Momentum Monitoring and Evaluation Innovation and Learning Working Group, which we call the MEILG Working Group, plays a critical role in the success of Momentum. It's a platform for collaboration and discussion that brings together leaders in measurement, innovation, and learning from across Momentum, tapping into other expertise from external partners and other working groups as needed. So we aim to provide technical guidance, build consensus, and routinely review what to measure, approaches for measurement, analytics and visualization, learning and innovation for use across the Momentum suite of awards, strengthening cross-Momentum measurement and learning. My colleague, Lara Vaz, who's a technical director of Momentum Knowledge Accelerator and a senior program director at the Population Reference Bureau, and I lead this working group. So we have a very interesting presentation today on data used for service improvements, which I hope will be helpful to many of you in your work. As we all know, effective coverage is defined as a proportion of a population in need of a health intervention that receive it with a sufficient quality to achieve the intervention's intended health gain. While there are several approaches have been used to measure effective coverage, most of these are statistically derived. They triangulate multiple sources of data and use complex analytical approaches. In this webinar, we're going to hear about an approach used in Lao PDR by the WHO in partnership with the government of the Lao PDR to monitor quality service delivery and use data for service improvements. Following the presentation, we're going to discuss the implications of this approach for measuring effective coverage. So to tell you a little bit about our speaker, we have Dr. Shogo Kubota, who's the coordinator, maternal child health and quality safety at the West Pacific Regional Office of the WHO. For the last 7 years, he has served as the team lead of the Reproductive Maternal Child and Adolescent Health Unit for the WHO Lao PDR Country Office, where he supported the government on maternal and child health, quality of healthcare, and community engagement and multi-sector governance for health. So he's a pediatrician by practice. And before getting into public health, he worked in humanitarian, primarily post-disaster management and refugee camps, etc., with the Red Cross. And before he studied medicine, he studied religious anthropology, the learnings from which he's found very useful in his current public health work. So before we get on to the webinar, I have a few housekeeping points. As was mentioned in the chat, we will have simultaneous interpretation of French. The interpretation button is at the bottom of your screen to select for French translation. So please keep your computers and phones on mute. For bandwidth issues, it would be good if attendees could turn off the video and stay off camera. We have a packed agenda. Dr. Kubota will first present for about 20 minutes, and we leave time for discussion. In the interest of time, please feel free to introduce yourself in the chat. And at any time, please put in your questions in the chat during the presentation. We'll take a few questions at the end and also draw upon the questions that come in the chat. We will be making a recording of this webinar and we'll share it with the group as well as put it up on the Momentum YouTube website. I'm going to hand this off to Dr. Kubota.
Right. Thanks, Soumya. Hi, everyone. Good morning, day, and evening. So my name is Shogo. Maybe if you could show this first slide. So I've been working in Lao PDR for 7 years and just moved 4 months ago to Manila, where the regional office is. One click, please. So I wrote apply effective coverage framework, but I think it's an overstatement. We'll click one. Yeah, it's more about learnings from trying to apply the effective coverage framework in the work that we have been supporting the government of Laos in nationwide healthcare facility quality assessment and improvement support. Next slide, please. So this whole presentation is based on the work that Lao Ministry of Health, and especially a national RMNCH committee and the secretary has led together with WHO Lao Country Office. Next, please. As I think many of you know, Laos is in the Southeast Asia, a landlocked country with 7.4 million populations. So mainly the healthcare is provided through public health, public sector with the national or central hospitals, 17 provincial hospitals, 130 district hospitals, and about 1,000 health centers. And Laos has, in the last few years, Laos has defined the quality, national quality standard, not only in RMNCH, but also in communicable disease and non-communicable diseases, and developed assessment tools and also as trained assessors. And especially for RMNCH, it has been rolled out nationwide to all provinces and selected districts in 2019. And since then, in some selected provinces, it has been there have been annual visit to all district hospitals for facility-based quality assessment and improvement support. So that's the background. Next slide, please. So how do they do? So they assess the quality through client interviews, the clinical vignette for cases that you don't see on the day of assessment, and direct observations. And also it's not here, but also chart reviews. And this takes about 2 days to do all the assessment in 5 areas of RMNCH. And that data is collected for analyzing and planning at the facility level together with the hospital managers. One click, please. The objectives are 5-fold. So there is an on-site technical support to the providers. So it's not only taking data, it's really about the feedback to individual providers as you do the interviews, you do the vignette, you do the direct observation and so on. And those data collected are all compiled on the 3rd day and analyzed and presented with all the providers and hospital managers for the hospital level support and planning for quality improvement. And those data from the hospitals are all aggregated in a provincial level for the provincial planning. And again, further aggregated in national level for long-term national strategic planning. And hoping that this data will be used for future accreditation. One click, please. Just as an example, so in this one district hospital where 10 mothers were, a pregnant woman were interviewed, only 2 out of 10 answered that they had their blood checked. And on the 3rd day, when the provider were presenting this to the hospital manager, and the hospital manager, the director actually of the hospital asked the midwife, okay, so why are you not taking blood? The midwife said, well, you don't allow us to take blood. That's, you allow only the doctors, but you know, in antenatal care, there are no doctors. So the director smiled and said, oh, okay, from tomorrow you're allowed. So you can see lots of the quality issues is not really dependent on the providers themselves, but a lot to do with the hospital management. And also some of them goes beyond hospital, such as procurement of the equipment that's more with a provincial level. And this one episode was interesting because after we went to this hospital, and actually with the Ministry of Home Health, we asked ourselves, was it really in the current regulation, are midwives actually allowed to take blood, order and take blood and interpret the blood by themselves? And we went back to the regulation, the scope of practice, and they weren't allowed. we thought, okay, I think we have to see all the, the essential services that are expected by midwives to be provided, and are they actually allowed? We did a mapping of the essential service package and the scope of practice of midwives, and we found that only 20% were allowed. So what the government is doing is that say, okay, this is what you have to provide, but most of them you're not allowed legally to provide by yourself without doctors. So after that analysis, the scope of practice was revised, and now 96%, if I remember correct, is allowed. So you can see this bottom-up approach, the data, either the quality assessment and the improvement in each level actually makes not only the change in the providers or the management of the hospital, but also legal framework and also the curriculum at the national level. So this is how this bottom-up quality assessment improvement is designed in Laos and has been routinized in some of the provinces. Next slide, please. This is one of the provinces that has been conducting this facility-based quality assessment and improvement support at every district in their province over 4 years, 3 times. And you can see the trend for each of the 5 areas: reproductive health, maternal, newborn, well child, and sick child. And one more click, please. So this is quite a complicated comprehensive exercise, and since the effective coverage is quite hot topic, so we try to actually apply the data we have to make a cascade of effective coverage. So we have to really narrow down what we are talking about. So we narrow down to maternal health, antenatal care in maternal health, and specifically on anemia prevention, screening, and treatment of antenatal care. Please, next slide. What we found from the data we have, we could make a cascade. Yeah, the 100%, that's the one who came to the hospitals. And the hospital which had all they need for screening and treatment for anemia was already down to 65.6%, most of which got an intervention. That's the iron folic acid prescription. But did they actually have a good counselings on taking iron folic acid to improve the adherence? And that you can see about 1/3 were getting the standard counseling that has to be done, and then the adherence that's a followed actual taking the iron folic acid was about 22%, so about 1/5. You can see the big reduction with the cascade. Now, please, one more click. That looks like the effective coverage cascade, but we didn't actually. This wasn't really necessary actually for in the process of identifying what are the health system bottlenecks and solutions in each level, from the providers level, hospital level, to the national level. But we could make the cascade. Next slide, please. One way that and instead of making a linear cascade, what actually was useful was this matrix. So it's the same kind of, the data, but making it into a matrix like this. If you see on the left side, it's an essential services such as contraceptives, antenatal care, delivery with skilled birth attendant, immunization, nutrition, and sick child. And then you see on the right side, on the top, are the elements of the cascade. You have the service contact, and then you have the input-based adjusted coverage, and then the intervention adjusted coverage, the quality, and the adherence. Then you can see each service has pain points, different pain points. Through this, you can identify what's the specific health system solution. For example, contraceptive, that's the issue with input. You have only implant in 12% of the hospitals, then you improve the supplies. And at the also there is a counseling on the benefit of long-acting reversible contraceptives, but there is not many people actually switch to Lux, and that's with the counseling skills. So this is quite useful because you see a different specific health system solutions and responsible people for each service. Next slide, please. For the cascade, it was useful for high-level advocacy. This is from a well-child clinic, 400 children or their parents being interviewed who came for immunization. You can see that only 20% actually got the screening on breastfeeding and complementary feeding. So 80% missed opportunities. So this advocacy, this was used as quite a shocking, graph being used to advocate the reorganization of the funding source, the funding stream, and also even the MOH structure. How to advocate the integration between immunization and nutrition interventions under the well-child clinic. Next slide, please. So some of the lessons. So the cascade of this effective coverage. In reality, first of all, the cascade, it's not as simple and it's not as linear, cascade that we can make because there is a lot of interactions between these different components, and also cannot always frame one coverage as a fraction of the previous coverage. So there are some methodological issues. And in terms of usage, there are many cases where metrics are more straightforward when you want to identify what's the health system solutions and accountabilities. The next point is on the quality indicators that impact health outcomes are context dependent. This is very important. For example, in Laos, antenatal care at least once, it's quite high, more than 90%. So the accessibility, yes, it's not perfect, but is not a big issue. They come at least once, they just don't come back. There's a huge sharp dropout to the return to the skilled birth attendant. In this case, what the antenatal care can do, the best thing that the antenatal care can do to reduce the maternal mortality and newborn mortality is actually the counselings, the good counselings on birth preparedness to make sure they return to SBA. And in other contexts, the quality factor that impacts most to the mortality is totally different. So you can see that kind of, we have quality indicators, but which ones are more important than others are very much context dependent, which is hard to actually be expressed when you make a simple, cascade. And effective coverage was useful for advocacy, but maybe it's in the practical level, there are other ways that are more straightforward. Next slide, please. This is another example of how complicated this cascade can be, because, for example, this is when you have a contact coverage. That means, okay, when they actually come to the hospital, do they receive, those people who needs to receive the family planning, do they receive? It really depends on who we are asking to. Are we asking to the family planning clinic, or are we asking antenatal care? Then more than half of them miss the opportunities for family planning, or well-child clinic even. Surprisingly, some people miss even when they come for the family planning clinic. But so again, it adds up another, the complexity in the real situation when we try to apply this effective coverage. Next slide, please. So the summary for the effective coverage, it's not only about the effective coverage, but it's more about the quality assessment improvement. It's the assessment, oftentimes, as you might know, some of the research around, the result of the health, the hospital accreditation doesn't really associate with health outcomes, and it is very difficult often when you are working on this hospital accreditation and so on. So how do we actually link the quality measurement and the quality improvement is a big agenda that we have to work on, and in Laos, what has been done is really don't separate the assessment just for the assessment per se, but do what the program needs to do, which is an improvement support. And to do the improvement support as a part of it, there is an assessment that has to be done, which can be used as a byproduct, but it can be used as a quality measurement. And we often talk about data should be fed back, but in ideal world, it should not have to be fed back because it has to be used in each level as it is aggregated to the national level. And so what's important, the last part, is that how much we decentralize the capacity of data-based planning and monitoring is the key. And that's really the focus of this work on how to, build the capacity in each hospital in data-based planning and monitoring. Next slide, please. So I have 5 more minutes. I started 15 minutes ago. So this is about effective coverage, but I will go a bit beyond the effective coverage, more in health, on the health system for quality. Next slide, please. As I think many of us know here, among the preventable death, more is due to poor quality than non-utilization. Next slide, please. That means if, maybe I can skip just to save the time. Next slide, please. So what that means is that if you're only monitoring the coverage, you're not looking even half of what we have to look at to actually monitor the progress towards mortality. So this is a good example. If you see in the middle, that's for all the low middle income countries, which all the countries have already achieved 80 to 90% of deliveries with skilled birth attendant, but you can still see a 4 times difference in NMR. So we should not only monitor, obviously, the service coverage, but also the quality. And are we actually monitoring the quality is the next slide and the second. Next slide, please. If you see SDGs 3, there are 3 things basically we are monitoring. It's a health outcomes, service coverage, and health behaviors. 3.1 to 3.9, you can see. But we are not monitoring the quality of healthcare globally, nor in many cases nationally. Maybe next slide, please. That lack of monitoring globally of this quality is reflected in a national health system information systems. What do we look at when we want to make a plan? Public health priorities, identify priorities, and making strategic plans. We look at the population data, we look at health outcome data, the service coverage data, and service quality data. How do we look at them? 2 clicks, please. So for the population, we have census every X years, and we have more frequent routine monitoring through CRVS. And for the health outcome and service coverage, we have census, we have DHS, we have mix. And for the routine, we have HMIS in each country. But what about for the service quality? Either survey or routine. So this is how little weak we are, where we are in terms of measuring the quality, considering the fact that quality might be more relevant in mortality reduction. All right, maybe one more slide. Was it, did I have, yeah. So this was just an example of health information system, how the lack of quality in health information system. But I think we can talk about each pillar. How do we actually mainstream this quality into different pillars of health system is what we have to work on. I think that's it. That was 18 minutes, great. Thank you.
Thank you so much, Shogo. I'm going to pass this on to Lara to facilitate the discussion.
Yeah, and thank you again, Shogo. This was, I've heard this presentation or an iteration of this presentation before, and it really is very thought-provoking and makes us think a lot about practical use of data and the utility of talking about effective coverage. There are several questions that are coming in through the chat. I would be happy to see more of those questions come through. And just a question that is less about the approach and more about the content, Shogo, and that comes from Pramila Bartlett, wondering whether care of the newborn is included as an essential service in Lao PDR, recognizing that perhaps it is included in delivery with a skilled birth attendants. But, to what extent is there a focus on the newborn, particularly in places such as Lao where newborn death rates might be higher?
Yeah, there is obviously, yes. For there is the latest version, the edition of the essential service package has 100 packages, not yet endorsed, but finalized and will be endorsed very soon. I think has 100 packages, hundreds interventions, and 50 something % of them are RM and CH, and then there is communicable diseases and non-communicable diseases, and within RM and CH starts from reproductive health and so on. But there are a few, I think maybe 2-3 interventions identified for newborn care in different level of facilities. Yeah, and of course the basic newborn care is pretty much required to every level down to health centers. Like early essential newborn care is a very, very big program in Laos, as well as in other countries in UPRO, our region.
Yeah, thank you. And I think, there are a couple of questions coming in around process and the ease of doing this. So first question from Balram Bui is around who carries out this process? Is this something that is led by government? And is it being carried out, in all facilities and some facilities, and what kinds of resources would be required?
Yeah, so it is carried out by the government, by the RMNCH. As I wrote in an acknowledgement, there is an national RMNCH committee, which has subcommittees. The 5 subcommittees, the technical ones are reproductive health, maternal health, newborn health, child health, which has immunization and nutrition, and sick child. So each subcommittee has, I think, about 10 members in a subcommittee, right? So they have a representative, and usually one each will gather and formulate a team of 5 together with a secretariat. Will go to each facility in the provincial level, and then also train the province so that they can assess themselves as well as they assess the province districts. I said assess, but again, it's really not only the assessment, but it's really about the supporting, the improvement in the different levels. So yeah, it's by the government, by each subcommittee in RMNCH committee. And yes, WHO is heavily supporting this since the beginning, several years ago. In 2019 was the first round. So this, but as you can see, this is a quite heavy exercise. It is a very heavy exercise, actually. So I would think if you remember the slide that, you have for population data, for service data, you have, simply put, you have one for the survey-based data collection, and then you have more routine health information system, right? For population, it's census and CRVS. So in that sense, this is more of a, say, every 5 year you do this to get the data, which is used in each level up to the national 5-year strategic plan. So the current actually national strategic plan is heavily informed by the nationwide, quality assessment. And at the same time, now we are working actually with the headquarters, and we will start in some of the countries in our region to identify what are the quality indicators, data that we can use to inform the quality indicators from the routine, recording and reporting. So hopefully in a few years, we will start to see some of the countries having this routine quality measurement and monitoring, both through the survey, say every 5 years or so, and also through HMIS. Sorry, I think I talked a lot more than what I was asked.
No, this is great. And actually I'm going through the questions and not necessarily asking them in order, just letting the everybody who's here, because it helps to with the flow of this conversation. I'm actually following up on your mention of the selection of indicators. Emma Sachs is asking about what other measures of quality that are routinely being measured at the system level, in addition to quality of intervention, and are any of those being used, such as cleanliness, experience, language accessibility?
That's language. That's great. That's great. Thanks for this. Yes, in Laos, as in many countries, I would imagine, has a framework on what is the quality of healthcare. And in Laos there are three, the classic Donabedian, framework of you have the foundation, you have the process, and you have the outcomes. And for the foundations, there are the process, you have all the clinical things, and as well as the people-centered care, such as cleanness, timeliness, and all that, the convenience and so on. And then you have more cross-cutting issues in quality, not specific programs, which are is there, for example, a surveillance system in place in terms of hospital-acquired infection, in terms of falls, in terms of medication errors and so on. So that the patient safety indicators that cuts across programs, right? And then you have back door. So that's pretty much in the front, with the interface with the patients. But once you enter the door, which says staff only, that's the back side of the quality, which you see about financial management, the human resource management, information system, and so on, right? And then beneath, as a very foundation, is the infrastructure and equipment and human resource. So that kind of structure, the first thing that we supported the government in Laos was having a very the comprehensive framework. And then from the framework, you have subdomains. And from the subdomains, you identify each domain, what are the core indicators by each department. For example, financial management is coming from a department of finance. So they identify these key indicators and to compile this one national quality standard. And the country has done a few in few provinces, the whole assessment of the whole our national standard beyond RMSH. It's a very big assessment, and because it's very big and you cannot have every, the experts in every field. So it gets a bit more tricky in terms of how that assessment is directly supporting the improvement in each facility and every aspect of quality. So, yeah. Did I answer the question? While I'm talking, I forget the original question. And
well, the question is, what were you capturing, looking at other aspects of quality, right? So,
yes, no, I think I did.
The language,
Oh,
accessibility.
yes. Oh, sorry. That's a good, thank you for reminding, Lara. So it's not only the provision, and as you see in the methodology, a big emphasis is on experience of care. So, and very interesting, there's one example, and thanks again, I forgot who, but you asked this question because, you see this provision of care. For example, you ask this question, or you check how are they actually doing the counselings on danger signs, maternal danger signs, right? And you see about the same level, and we have disaggregated data by ethnic groups, yeah? You see pretty much the same level of provision of care in terms of counselings on danger signs, right? And then on the other hand, we have on a question from exit interview, what were the danger signs that you have heard when you are in this clinic, right? And there's a huge difference between Lao and other ethnic groups such as Hmong. So that really tells, from the experience of care, the inequity that we have to tackle and so on. And that informs back to the national policies on how do we improve the counselings for those non-Lao speakers and so on. Okay, so I think I answered.
Yeah, no, and Shogo, how, I think one of the questions, and this is from Carolina De Navarro, how are when you see the differences or the discrepancies, how are they handled to ensure that they're addressed within the reality without retaliation? So I guess that's the question from Carolina.
Without what?
Without retaliation or without...
Good questions. All good questions. I'm very happy. And because now we work. Okay, so this is maybe I can go beyond Laos. Some of the work that we have started is around hospital-acquired infection. As you know, the IPC just the last month World Health Assembly IPC global action as one topic, and it's and IPC, if you take one single outcomes for IPC infection prevention and control, it's a hospital-acquired infection. But then surprisingly, they're so difficult, and you don't find many hospitals that has a good monitoring system, surveillance for hospital-acquired infection. Some they do that, but if you, I don't name the countries, but they have a data. It says 0.1%. Right, and then we actually do it on site, going through a chart review. Some of the units in some hospitals have 40% of hospital-acquired infection. 40%. So people who come to this hospital, to this unit without infection, 40% will get the infection, right? And what I was surprised in this one particular hospital in one country, which I won't name, when the 40% came out, what I was surprised, it wasn't how high, how bad it was. It was about how open they were in saying we had 40% of hospital-acquired infection. And I asked why this came out. And it was the immediate answer to this was we have a good leadership. They encourage us to show what's the issue, and we tackle it. So this patient safety issues has so much to do with the leadership on how to cultivate the culture of non-blame culture, and the safety culture. And also there is a lot of space that we have to still improve a lot in most of the countries in terms of how do we engage the patient, how do we engage the family and the community in improving the quality and safety. So I think all these things has a lot to do with, non like a technical work, but more on developing, and nurturing this culture for the collective, supportive environment and safe environment to see what we see. Lara, you are talking muted.
I just am seeing a lot of comments, great presentation. I think this discussion is a really fantastic one, and I'm enjoying the comments that are coming in. I wish that we could break out into smaller groups, and perhaps that's a follow-up for another session where we can actually get into some smaller groups and talk about, sharing some more experiences around this. You've mentioned the assessments and the role of government here. There were a couple of questions. One from Kola Oyediran around the integration of the quality of service monitoring into supervisory and monitoring visits, which I believe is what you've mentioned, and the sustainability of that. How does that work? How do you go from, what did you need to do to integrate it? How easy was that? And then also, how do you make sure that after this improvement plan, what kind of monitoring, what do you need to do to sustain that process, and to actually see an improvement based on the assessments?
Yeah, I think, for the sustainability, we can talk about the technical competencies and also the financing and maybe a few other things. But as you saw from the presentation, it's again, it's really not about assessment. It is about the core mandate of the technical programs, the experts who go from the central hospital to the province to the district to support the improvement, right? And then to do so, we have to acknowledge what's the current situation. So it's really the process of what I think we have been doing the whole time with any programs, you name, the communicable diseases, RMSH, nutrition, whatever you name it. That's what we have been doing. It's just that there is some discrepancy, gap, the disconnect, I would say, between more recent, it's not recent anymore, but still on the quality assessment, measurement, accreditation, result-based payment, all these things has come when there had been a decades of, the program, efforts on quality improvement. And each country has to really take an effort to link these two. And again, we do hear some, countries where, okay, this is again quoting from a country who is working on early essential newborn care, saying that, we spend so much time going and, doing coaching and monitoring and all that, but then the assessors come and then they assess and they pay for it. And so all the providers are looking at them, not us, So I think that kind of, this disconnect between all this overarching, the quality assessment and improvement has to really come together. And that actually will also ensure the sustainability, because when we do this, often what we hear about the criticism is that it costs a lot of money and it's very, very labor intensive. And I don't deny it is. But if you think about all the programs every day, the investment that they are spending for improving the quality, and if that can be linked to the assessment, the measurement, and the monitoring of quality, it's actually not, I would imagine, this is without data, so it's my impression, but I would imagine you can actually save cost. Yeah, so I don't know if that's answering the questions of sustainability from, technical and also financial aspect in terms of measuring the quality. But at the same time, as I said, even though this presentation was more focused on the facility-based assessment and improvement support, there is a whole area that we have to look into in terms of the opportunities we have for measuring quality through routine recording and reporting.
Shogo, since we are hosting this through the monitoring and evaluation and innovation and learning working group, I'm going to shift us a tiny bit from talking about quality of care per se and the measurement, but to talk a little bit more about the measurement specific issues. And there are a couple of questions around that. One from Camilla Bartlett from USAID around the success in integrating quality measures into HMIS. So to what extent has Lao been able to integrate these quality measures into HMIS or other systems, perhaps not HMIS? Also recognizing that, as you said, that these are fairly labor intensive. So how frequently does the measurement occur? So I'm going to start with those two questions.
Okay, so in terms of integrating to the routine health information system, I think that slide that I showed and one of the last slides, what kind of data that we need to monitor, measure and monitor, and what are the common ways we are monitoring. There are, simply put, there are two ways. Yeah, one is about this, a survey that can happen once in every 5 years or 10 years, such as census, such as DHS, such as MIX, right? And then you have this routine monitoring, which happens with CRBS for the population or HMIS and in coverage and outcomes. So we do have to think two ways, and you have one for routine monitoring, you have one more intensive survey which calibrates, and double or cross check the routine monitoring. So if the question depends on which one you're talking about, and if you are asking the survey, I think what now the Laos is doing is just to start and have started the rollout of the second survey, which is now in 2023, right? The first one was in 19, so it's about 5 years, which is great because then this will inform the next 5 years strategy. So that's a bigger routine cycle. And then in terms of routine data, so this is the work that we are just starting, and I know in some of the countries the headquarters has actually done very interesting work around identifying in a facility. What we do is going through the patient pathway and see, the patient first you arrive and you have write certain things that might have a history in there. And then you get, at one point you have a desk for blood pressure, and that is recorded somewhere else. And you have all these, points of data, the actions, the care that is provided, and there is a recording. And how that, and more, what I heard from other countries is that most of the data is not being used. So we do have to see where are the opportunities, where the data is actually collected with different forms, and how that actually can, come together in a more systematic way so that it can inform, the quality indicators for less intensive, routine measurement and monitoring. So I think those are the two layers that we have to strategize. And we, in the next few years in Western Pacific, we will be working on and hopefully having a few countries that can really show this routine measurement and monitoring, both through this survey, say every 5 years or so, and then with a routine record and reporting. So that's really one of the work that we are now started to work with a few countries in the region.
It's very exciting. I'm looking at a few other questions again around the methodology. Do you have documentation of the tools and the methodology that you would be willing to share with participants from today? And also, would the slides be available is another one of those questions.
Okay, okay, that's yeah, sure. So there are lots of thick books on this the facilitators guidance on, and that has to be, it's pretty much there with pretty much the final version, which weren't yet endorsed by the government. So hopefully soon we can share them. If you have a way that you can, we can share with you and you can disseminate, I think that's good.
Absolutely.
I just have to do it until
I think what we can do is since we're recording this and we can post this, we can also make sure that after the event, the page that currently has the announcement for this webinar will host the recording, and then as the materials become available, Shogo, we can also put the materials, including your slide deck, if you're willing to share that. And so it would be on the USAID Momentum website, and then we can also link it to the recording. We will be posting the recording of this on the USAID Momentum YouTube channel, and then we can also put the links to the materials. So I think it gives us an opportunity to share that. Another question tied to the data.
Sorry, just about sharing. So the ones which are developed, these 5 areas in RMNCH, the assessment tools and improvement support guidelines. These are not yet endorsed, so it's a bit difficult to share at the moment, which hopefully will be. But that's in Laos. But as a regional office, there are tools which have been tested in more than a few thousand facilities for newborn care, which is early essential newborn care. So that's a very strong, very practical tool. And we have every 2 years we have a good, the measurement and the monitoring of the quality of newborn care from 8-9 countries every 2 years. So that's now in the process of collecting the 4th round. So maybe that one is something that I can share right away, that you have the 3rd biennium report, and you will see how it's structured and what are the actual, you have the tools, so you have the questions, and also you see the profile of each country. That's for newborn care. We are just starting to develop the one for maternal, intrapartum, and antenatal care. Hopefully by today, next year, we have that published, or even before that, let's see. But yeah, I think I can share already a few that we have published.
Wonderful. I'm trying to run through what is a really exciting discussion that's going on in the chat, and I'm very excited to see all of these different pieces. There seems to be a whole chat very much focused on the content of quality of care and what's being assessed in quality of care, and how do you decide what to look at within the quality of care standards. And then a lot of questions around the data itself, in terms of where are the data, for example, where are the data stored? How are the matrices developed, and where do they reside, and who has access to them? So those are 2 questions, and I'm recognizing that we're about to run out of time. So if you can answer that shortly, it sounds like we are going to probably have a next discussion around this. So we probably will do something separate. But anyways, Shogo.
Okay, you said 2 questions. I remember only the second question, which is where is it stored? For regional data, it's in a database which I have to see if it's open to public or not. But for Laos, those are all in DHIS2. It's still in the transition from paper-based slash Excel. But this all the things are all in DHIS2. We just have to, and then there are tablets. So that has to be done. It's in the process of transferring. So not yet you can now click and see the data, but it will be so hopefully again soon.
Yeah. No, it seems like there are two separate conversations that we would love to be able to follow up on. One is really around the approaches and actually addressing quality of care, and there seems to be another very active conversation around measurement and selection of indicators, the parsimony of indicators, the adoption of this approach and the extent to which something like this would work in the private sector as well as public sector and how that would be done. I want to thank everyone for coming today. It's a really nice wait for those of us who are still in the early morning to start off our day with such a great conversation. I think for folks who are in the Western Pacific region, including Dr. Shogo Kubota, I hope this has been a great way to end your day. And for those who are in the middle of their days, I really am hopeful that this is really inspiring that spark in the afternoon. I want to thank everyone for your participation today and for your engagement. As I mentioned, the webinar recording is going to be available on the website and linked into our YouTube channel, and stay tuned for that information. We will share that. Shogo, let's follow up, and if you're willing to share your slides, we can put those slides up as well. We can and have them available. And you're quickly developing a fan base, because there are several people who have asked for your contact information. So we are, again, very grateful for your time. And I want to thank everybody for joining us today. We look forward to seeing you and everyone else at our next webinar, which will be in September.
Thanks, Lara. Thanks, everyone.
Yeah, thank you, everyone. And yes, that we will be sharing the presentation. Bye all.